Hi everyone, welcome to Dr. Deepa's Learning Launch. I'm Dr. Deepa and I'm here to discuss with you another very important case in genitourinary pathology. So this is a partial nephrectomy specimen of a 54-year-old gentleman who was a chronic diabetic and moribund with recurrent history of UTIs who presented with loin pain, and a partial nephrectomy was done in suspicion of a tumor. But the microscopy revealed something that wasn't malignant. So let's take a look. This is Malakoplakia. This is a low power image. Let's zoom further. Malakoplakia is a rare chronic granulomatous disease. It's an inflammatory condition that results from a defective macrophage function. So the term Malakoplakia is actually derived from Greek, which means a soft plaque. And that's what it looks like grossly, as a yellowish soft plaque, which resembles a malignant lesion at most cases. So the disease occurs because the macrophages are unable to essentially digest the entire phagocytosed bacteria, and it remains in the lysosomes. And most commonly, it is associated with an E. coli infection, which is the commonest UTI causing agent. As a result, the partially digested bacterial entity remains to accumulate within these macrophages, leading to a characteristic histological finding like this. So the malakoplakia most frequently involves the genitourinary tract, as I told you. It can involve the bladder commonly. Sometimes it involves the kidney, the prostate, the GIT, and it can also involve the lung, skin, and sometimes it also involves the lymph nodes. So you have to keep your eyes open for this lesion. The patient often is immunocompromised, in the sense he can have an associated HIV infection or any chronic moribund disease like any paralysis or any reason for which he's been chronically ill for a long time. Or it can be a patient post organ transplantation. It can occur in any chronic debilitating disease and even diabetes. So in these conditions, there is recurrent UTI that keeps troubling the patients, and that is why these infections are something in which the macrophage gets overwhelmed because of these recurrent infections, and the resultant lesion looks something like this. So grossly, they appear as yellowish plaques, like I already told you. That is where the name of the Malakoplakia is derived from. Sometimes it can also be a nodule, a mass, or even some soft friable lesion. Microscopically, the hallmark is very clearly the presence of Michaelis-Gutmann bodies or von Hansemann cells. These large macrophages that you're able to see here are called von Hansemann cells. And they're the ones that have tigroid, or the ones that have target-like areas that you're able to see right now in this field itself. So these are called Michaelis-Gutmann bodies. The Michaelis-Gutmann body represents a partially digested bacterial debris that has undergone mineralization. Most of the cases, the mineralization is because of calcium in about almost 90% of the cases, but sometimes even iron can be the mineralization over these partially digested substances. So the inclusions appear as somewhat tigroid, somewhat bluish, and somewhat targetoid type of an appearance. You're able to see many such Michaelis-Gutmann bodies in this whole slide image. Sometimes if it is very difficult to diagnose and there are very few Michaelis-Gutmann bodies, then you can use special stains that will bring it up. This particular whole slide image is having everything very clearly, and there are many Michaelis-Gutmann bodies in this particular slide. But sometimes you can have just one or two Michaelis-Gutmann bodies and a chronic sheet of inflammatory cells of lymphocytes and plasma cells also, other than the macrophages. So in those conditions, you might want to use a PAS stain to delineate the macrophages. You might want to use a von Kossa to see the mineralization via calcium, or you might want to do a Prussian blue stain also, which can delineate a mineralization with iron. Nevertheless, the diagnosis of Malakoplakia clearly puts it under the chart of an inflammatory lesion and not as a malignant lesion, although it looked malignant grossly. So the differential diagnosis is xanthogranulomatous inflammation that can cause it. Any lesion that is any histiocytic proliferation can mimic Malakoplakia, and there can be fungal lesions also that can mimic Malakoplakia. And sometimes you might want to go ahead and look at this with as a progressive entity also. If it's a bladder biopsy, a small bladder biopsy, you might want to retake a biopsy after an antibiotic therapy. That will clearly give you a subsiding lesion kind of a picture. So after the correction and surgical excision, or if there is a large area involved, if there is a surgical excision made also, the diagnosis of Malakoplakia primarily rests on recognizing these von Hansemann cells and Michaelis-Gutmann bodies. So this is all from me today. So if you like my video, and if you are interested in following, then please follow www.drdeepaslearninglaunch.com for many more such educational content.